We are honored to invite Dr. Mascarenhas here, so please give a warm welcome to Dr. Mascarenhas.
Thank you so much. I am going to try and share. All right. Are we good, Mala? Perfect. All right.
Yes, everything looks great.
So thank you so much for inviting me to speak, and I'm delightful to start off the new start, the year in September, the month in September. And I loved your meditation, so thank you so much for that. So today I thought I would talk about pediatric integrative medicine, talk about some conditions, and then if we have time, go talk about our program at the Children's Hospital of Philadelphia. So I'm going to start off with a case that some might resonate with some of you. So in April 2021, Lara, an 18-year-old girl, developed nausea, abdominal pain with worsening symptoms when she ate or even when she looked at food. Initially, there was some improvement with erythromycin, which is a prokinetic medication, less pain, less vomiting, but then her symptoms progressed. She started cyproheptadine about 2 weeks prior to admission without any improvement, and then she was admitted with a weight loss of about 20 pounds, vomiting, pain, reflux, chest pain, and nausea. So when you look into her history, and I'll come to why this is important later on, she was born to a 15-year-old mother with no prenatal care. She was cared by a maternal grandparent since birth. She does visit her mother's stepfather and 2 step siblings. Her stepsister was involved with Children's Protective Services, and she admits her mother is not the mother she wants her to be. High school student who wants to go into healthcare and high GPA. So I think that I'm painting the picture for you of this patient. So she went through an evaluation by one of my GI colleagues before she was referred to our integrated GI clinic. And significant was a low vitamin D level, low iron saturation, and gastroparesis. She was started on NJ feeds, documented weight gain prior to discharge, and then in 3 months' time, she was able to wean off the NJ feeds onto some kind of a diet. So we'll park that for now, and then we'll come back to Laura at the end. So I know you all know what integrative health is, and I know you all know what the definitions of complementary, alternative, and integrative medicine are. But I wanted to share with you, one, the Pediatric Integrative Medicine Wheel of Health in the University of Arizona program, and then the new Whole Child Wheel of Health that we have put together this year at CHOP. And in the center, and I'm sure this is true of your program as well, we have the child with their family and the typical things that we think about, for integrative health. So sleep, nutrition, movement, play, environment, loving and healthy relationships. And we encase that in some of the other things that we know are critical to patients: healthcare access, education, behavioral health support, spirituality, respect for culture, mind-body connection, caregiver and well-being and knowledge, and then financial stability. And we surround that with the conventional complementary care, community center programs, research and policy, which I know you all do at your institution as well. So this is our concept of whole health, integrative health, of what it should be. And this is what we're striving to do in all our programs. So I know you all know this, but I just want to bring you back to this because we're going to come back to this periodically throughout the presentation. So as defined by the NCCIH, integrative medicine consists of natural products, other healing systems, and mind-body practices. And under natural products, we have herbs, vitamins, minerals, probiotics, nutrition, dietary therapies. Under mind-body therapies, I've listed what we typically refer to. And under healing systems, I've listed the ones that we typically refer to as well. So moving to how common is integrative health in pediatric GI conditions. So in 2002, a survey done by Day et al., they found that 36% of patients with GI disorders had present or recently used more than one type of CAM. In 2008, from Europe, 38% had used CAM in the past year, of which 60% specifically aimed at treating their GI conditions, not just overall health. Wadera, again, in another country, I think this was New Zealand, Australia, said 69% were using or had used CAM, and the most common things were supplements and probiotics. And then in 2014, from Canada, there was combined CAM use in 2 pediatric GI clinics, 69%, with 42% using it concomitantly with prescribed GI medications. And I think it now might be even higher, but there was no more recent survey I could access. And then I just want to talk briefly about the goal of mind-body interventions, because a lot of what we do pertains to this. And really, we are counteracting the stress response by stimulating the vagus nerve. And it does all these wonderful things with just simple breath work, which is just amazing to me that thousands of years ago, people had figured this out in traditional Chinese medicine, Ayurveda, and other forms of traditional medicine. And briefly, the big connector between the brain and the gut, and we're going to come to this brain-gut axis further in the presentation, is the vagus nerve. And if you see 90% are afferent nerves taking messages of inflammation, satiety, fullness, hunger, energy metabolism, and then 10% is controlling gastric secretion, enzymes, motility. And the connection is modified through the autonomic nervous system, aka the vagus HPA axis, the hypothalamic pituitary axis, influencing the enteric nervous system and the microbiota. And we know that stress can affect this delicate balance and can lead to neurotransmitter release, mucosal immunity activation, barrier disruption, dysmotility, secretion disorder, increased permeability, bacterial translocation, leading to dysbiosis, which we see in irritable bowel syndrome, and then inflammation in inflammatory bowel disease. So briefly going through the literature of mindfulness in GI disease, in irritable bowel syndrome, it was found to be improved functional disability, symptom impact, anxiety, and it was consistency between parent and child measures. And there have been several adult trials showing improvement in IBS-related quality of life and symptoms of both in-person as well as virtual intervention. In inflammatory bowel disease, there were two meta-analysis. One was all adults, one was adult and pediatric studies, where they showed improvement in quality of life, anxiety, depression, no major differences in perceived stress in the short term, but improvement in long-term scores, and then positive improvement on inflammation markers, but not statistically significant. Then there was this pediatric study by Kohut in 2020, which again showed that group attendance, home meditation practice was satisfactory, and there was significant differences in emotional functioning. And then we had done a pilot study here during the pandemic, which hopefully will get published soon, which showed again feasibility, acceptability, high rates of attendance and satisfaction, and potential benefits in quality of life and stress. What about hypnosis? So hypnosis, I think Fliger et al. Are the queen and kings. They are the leaders in this field, and they've shown very nice RCTs looking at demonstrating both short and long-term improvement in symptoms and higher remission long-term in comparison with the control group. So very, very nice data. In inflammatory bowel disease, mainly adult studies showing improvement in both disease and activity. There was one 12-session decreased steroid use, another prolonged clinical remission in UC patients, and then one pediatric study in Crohn's disease, which I'll come to later on. And yoga, functional abdominal pain, there was decreased frequency and intensity after 10 sessions, which was sustained at 3 months with quality of life, improved quality of life. And then in irritable bowel syndrome, there was systemic review showing it was safe and feasible, decreased pain, improved sleep, pain, ability to practice at home. And then in a comparison with FODMAP, low FODMAP versus yoga, there was improvement. And then in inflammatory bowel disease, there was a pilot study with 9 adolescents with IBD, again, very small but positive outcomes. And then more recently, there was a longer study by Alicia Leiby, and we were one of the sites that were participating in it, and I'll come to it later on. And then how about massage? I think we all know about improved weight gain, decreased length of stay, improved parent-infant interaction, sleep patterns, and respiratory function in preterm infants, mainly because that's where most of the literature is, but also in term infants. With constipation and diarrhea, there's an improvement, one paper, and we are doing a study right now in IBS at CHOP, and I'll share those results. And then interesting, diarrhea also, there was improvement in acute diarrhea when compared to pharmacotherapy. And then functional dyspepsia, it's mainly been with tweener, but again, less dyspepsia, shorter time to resolution of primary symptoms with lower recurrence rate. And they also showed serum motilin levels were elevated, but no change in neuropeptide Y levels. So we're going to move on to inflammatory bowel disease. And so we know that this is a complex condition that's increasing in the US. We probably all know about inflammatory bowel, about Crohn's disease and ulcerative colitis, and then there's the in-between spectrum. And we know that there are 4 factors that are very important for IBD. One is genetic factors, the microbiome, the environment, the immune response. And so your question for me was how does inflammatory integrative health or CAM impact this? So in conjunction, and this is very important, it's in conjunction with standard therapy, we think that herb supplements, dietary therapy can be helpful, and then all the mind-body modalities, including dietary therapy, can help with stress. So what do we know about CAM use in pediatric inflammatory bowel disease? So for patient use, we know that 30 to 50% of patients for IBD have used CAM therapies. And in one tertiary care center, it was reported as high as 84%. Now, given that it was a tertiary care center with referral of patients, that could explain why the number was that high. Most commonly used therapies are usually stress management and relaxation techniques, included guided imagery, exercise, including yoga, and then natural supplements, probiotics, and vitamins. How about provider attitudes of academic IBD specialists? So only 33% initiated the conversation about CAM use, and 65% reported no formal training, while the vast majority believed that CAM had a role in adjunctive IBD therapy. And it would be good to repeat this survey now to see whether people's attitudes have changed. Because I think that integrative health, integrative medicine is clearly infiltrated or integrated its presence into a lot of medical care right now. So coming back to that figure we talked about, so in the healing evidence systems, I didn't find any evidence. But for natural products, I think there's a robust literature looking at plant-based anti-inflammatory diet, exclusion diets like the specific carbohydrate diet, gluten-free diets, dairy-free diets, low FODMAP diets, especially where there's an element of irritable bowel syndrome that floats into the patient with inflammatory bowel disease, the IBD anti-inflammatory diet, the Crohn's disease exclusion diet, the Mediterranean diet, and then exclusive enteral nutrition, where you just get tube feeds with a standard tube feeding formula. For supplements, there's data on turmeric, probiotics. We'll talk about fish oil, cannabis. There's minimal, but people have talked about using it. And then vitamin D, which I'll talk about. And then people have also used tritura, or the pork tapeworm, to help stimulate the immune system. Very small study several years ago, but I put it there, being that that you should be aware of this in case your patients come to you and say, "What about the study that I read? We don't use it," and I think it's not popular, but there was a study where they showed some improvement in patients, very small. And then mind-body therapies. I think we'll talk now about yoga. I mentioned mindfulness, hypnosis, acupuncture. There's some very nice pilot work going on at North Shore Hospital in Long Island using a vagal nerve stimulator in adults. And now there's a pilot study going on in children where they're using a typical vagal nerve stimulator device that you'd use for patients with intractable seizures, and they're actually studying inflammation in the gut microbiome, as well as specific disease outcomes, IBD outcomes, and showing some nice improvements. So be tuned for this. And I love the fact that there's this external device, this vagal nerve stimulator, and we know through centuries other ways of stimulating the vagal nerve without using a device. So, but more to come on this topic. And then physical activity and exercise, and then psychotherapy, cognitive behavioral therapy, solution focused therapy, multi-component behavioral therapy, and stress management. And while I can't go through the literature on every single one, I'm just going to highlight a few things. Okay, so I think the most popular is the anti-inflammatory diet, aka the Mediterranean diet, and there is literature that's growing in this area. So, if you're interested in this, I would encourage you to take a deeper dive into this. But for the exclusion diets, a specific carbohydrate diet, and Seattle Children's is the lead. They have wonderful educational documents in this. Exclusive enteral nutrition, where it's tube feeds. There are many countries in the world where when a patient is diagnosed, they will offer patients this therapy first without medications to bring the disease under control, and then as you wean off the tube feeds, layer on medications. And then Crohn's disease exclusion diet. This really started off in Israel. Again, wonderful results with it. We actually are in the process of completing a trial here in partnership with the researchers in Israel to see if we can wean these patients off their meds with just the Crohn's disease exclusion diet. And as you probably have figured out, it's hard to maintain this diet, but there has been a small number of patients who've been able to stay off, but some of them do relapse at varying intervals after they've come off their biologic or their other medications. So the pros are relative little side effects and effective inducing clinical remission. And I haven't shared the studies with you, but it compares very favorably with steroids with less side effects, etc. But the cons are it's hard to maintain. There's no long-term data, and there's maintenance of remission. But what about mucosal healing? And that mucosal healing has only been there for some. So by itself, I think dietary therapy alone is not effective. But I wonder if there would be a way to layer on vagal strengthening or other modalities and the true integrative approach where we pull in lifestyle measures. Of course, then we have to change the environment we live in, which is harder. But I wonder whether the integrative approach where diet is one of the pillars may actually be successful. And I showcase here the anti-inflammatory food table. This is a modification by Hilary McClafferty from Arizona of what the food table should be. And if you see, the bottom rows are layered with lots of fruits and vegetables, all colors. And then as you go up the pyramid, you have less and less of these, but we have herbs and spices, again, any amount, whole grains, protein-rich plant foods, then animal fruits, dairy, calcium fortified, dairy alternatives, healthy fats, sweets, and then lots of water, decaffeinated teas, etc. So I'm going to highlight a few studies. This is one that's on adherence to Mediterranean diet, is associated with a lower risk of later onset Crohn's disease. And this was from two large prospective cohort studies at the Swedish men and Swedish mammography studies over 20 years. And if you see, they had 164 cases of Crohn's disease, 395 cases of ulcerative colitis. And what they found was that the higher MMed score, which is the Mediterranean Diet Index, was associated with a lower risk of Crohn's disease, but not UC. And the prevalence of poor adherence to the Mediterranean diet conferred a population attributable risk of 12% for later onset Crohn's disease. So this is more prevention. And then this was a study looking at the way the Mediterranean diet can impact IBD patients, not just for active disease, and you can see but also for steatosis. And they found there was significant reduction in BMI and liver steatosis in both Crohn's disease and ulcerative colitis. And then there was spontaneous improvement of disease activity and inflammatory markers. And there are many other studies along this theme, but I wanted to share with you just how powerful changing the diet can be. Now, dietary supplements, a lot of patients are using them. And I think there are 4 that I want to mention. So one is curcumin. And I'll have a slide just on this, so we'll review the data. Green tea may be effective, but the studies are very limited. I think green tea is harmless. Vitamin D is really important, I think. And there is data that vitamin D can help. It's not going to cure your IBD, but having a good vitamin D level within the therapeutic range helps with prevention of remissions. Prevention of relapses, but and maintains remission. So whenever I do consults on a patient with IBD and they want an integrative approach, that's one thing I make sure that they've had a vitamin D level or their intake is good to make sure that's an easy thing to take care of. I warn patients that sometimes insurance companies may not cover the cost of this test and they might have to pay for it, but it's a small price to pay because once you know where they are, then you can adjust their levels and dose. And then supplementation with VSL probiotics. So this is the curcumin data, more with ulcerative colitis, and it's shown to induce remission in mild to moderate, so not severe, more mild to moderate, in combination with mesalamine versus placebo plus mesalamine. And that was in Lang, and then Hanai also had a study, and they showed that the relapse rate was significantly lower. So in pediatrics, and that's the pinkish kind of box there, a very small study where it was really a tolerability study, and increased gasiness was the only symptom. There was a decrease in the PUCA. These are outcome measures, but no relapse or not had relapse or worsening. And you can see the improvement in remission or the remission response rates, and then the endoscopic response rate, remission rates from the Lang paper. Now, how about probiotics in fish oil? So there's lack of evidence really for probiotics in fish oil. So specifically, probiotics really help with pouchitis. That's when patients have had a total colectomy and they have a little remnant pouch there. And then also to prevent antibiotic-associated diarrhea. And these are American College of Gastroenterology guidelines, which we follow. But fish oil, though it has anti-inflammatory properties, there's no evidence in IBD. So we used to have patients who would always go on fish oil, and we don't recommend it now. Some of them still want to have fish oil, but so we let them do. I always say have salmon or have clean fish rather than take a supplement. So how about hypnosis? As I said, there was one study where they had 40 subjects in the hypnosis arm or waitlist controlled. They looked at the primary outcome measures. It was an 8-week intervention, and again, recordings. And they noticed there was significant improvements in hypnosis quality of life measure compared to waitlist control. And there was an improvement in social functioning, school absences, and abdominal pain severity. Again, one study, and hopefully there'll be more that will reinforce this. How about yoga? This was a paper I mentioned from Alicia Leiby's group, where they looked at a 12-week intervention yoga program for patients with IBD 10 to 17 years. Patients that completed 9 or more classes, 73% were Crohn's, the rest were UC. They saw significant improvements from the beginning to 3 months post-yoga in the impact score, PEDS-QL, and the general self-efficacy score. And 85% of patients practicing yoga reported improved stress control as well. And given how I showed you how stress affects that mucosal barrier with permeability, immune, etc., and that yoga works through vagal nerve strengthening, you can almost imagine how moving in the future we could combine these measures. We could help our patients move towards health. Now, I want to talk about this term, which may not be as prevalent in pediatrics, but in pediatric GI and adult medicine, this is the way everything is going. So this disorder of brain-gut interaction, I've listed the examples of things that we thought were reflux, constipation, irritable bowel, abdominal pain, functional dyspepsia, rumination, colic are some of the examples of these disorders of gut-brain interaction or brain-gut interaction. It doesn't matter. It's bidirectional. It circles. So this is a condition that affects more than 1/3 of people worldwide. So just imagine that more than 1/3 of people worldwide can have a disorder of brain-gut interaction, and this seriously challenges health and quality of life. We used to say organic disease and functional disorders. We don't use functional disorders anymore, though that might creep into the presentation here and there. It's really DGBI. So mouth it's a mouthful, but once you say it, it becomes easier to say. So we know that DGBI often originates in children, and 20% will persist into adulthood. So as pediatricians, we need to recognize and see how we can help our patients so that they can not follow this 20%, fall in this category. The at-risk children are those with anxiety and mood disorders. And I don't know about you all, but I'm seeing more and more kids with anxiety disorders. And I think the pandemic just accelerated things. And I haven't seen a decrease in that clinically. I think we're still seeing more and more kids because some of the habits we learned during the pandemic have stayed and have not gone away. The pathophysiology really, and this goes back to what I showed you, that cartoon picture of the brain-gut interaction. Is there motility disturbances, there's visceral hypersensitivity where you overreact to normal sensations from your gut, there's inflammation, altered mucosal immune function, there's central nervous system processing abnormalities, gut microbiome changes, and psychological alterations, which we will review. And typically there's a cluster of symptoms: pain, bloating, diarrhea, constipation, and like Laura, I don't like food, the smell of food, the sight of food, even thinking of food bothers her. And there's a big overlap with primary eating disorder symptoms. So for those of you who see kids with eating disorders, adolescents with eating disorders, there's this huge overlap, and you really have to address both. And I'm going to talk about POTS very briefly a little bit later in the presentation. So there's a lot of research going on in psychological profiles, microbiome, social media, the diet, etc. And we know that for these patients, conventional treatment is not always successful, and non-conventional treatment is increasingly popular. So some of the modulators, this is a very nice paper that just came out on social media. And so we know that it's increasing. We know that time spent on social media impairs sleep quality and decreases physical activity. The excessive use contributes to anxiety and depression, which could be why this is continuing to increase. And then the increase in these disorders is at least partially explained by the increase in social media use. And I put this cartoon here just to highlight all these inflammatory mediators and neurotransmitter precursors that are generated in the gut. And there is a role for probiotics to help, and diet to help modify this, but more to come on this topic. Now, I said I would talk about psychological distress. This was a nice paper from Cincinnati Children's, and they showed that children with DGBS, and this was like 1,100 patients or something, a very large number, had higher anxiety, emotional sensitivity, and somatization, and lower coping efficacy compared with healthy youth. And they highlight the importance of addressing and appraising psychological distress, and then incorporating conflict resolution, assertiveness training, and resilience building during the treatment of DGBIs. Because sometimes DGBIs start off with stressors that would we say normal childhood stressors, but these patients, because they're programmed this way, it escalates. We looked at stressors in a group of patients at our food reactions clinic with food intolerances. Our hypothesis was that ACEs would lead to disordered eating, abdominal pain severity, and irritable bowel syndrome. And we looked at a bunch of therapies and symptoms. And we found that 75% of the patients we saw had stressors. And 44 at 1, and then 2, 26, 3 or more, 5%. And the patient participants with resilient strategies was 71%. Of course, we self-select out a pool that are coming to our programs. And the patients were using integrative modalities was 52%. And then when you looked at the strategies they were using, they would be simple ones, right? That aren't necessarily our integrative health. That could be pediatricians who have no integrative medicine training. So sports activity, music, friends, breathing, mindfulness, TV. Yes, TV was a resilient strategy, reading, and then bath or nap, and then less frequently some of these. But I put that there showing that resilient strategies can be widespread. You don't need fancy technology, and it could just be stuff that we grew up with before the world, and I grew up with, since I'm much older than most of you, than what we have right now. Okay, so I put this here because this is a practical guide to the behavioral treatment, and this is a very nice paper if you are interested in reading about it. So the one thing we have to see when we see patients, whether we're pediatrician or pediatric GI, is that Too much testing is not good. This over medicalization of DGBI is not good and could actually be harmful because there are many patients that hop from center to center, doctor to doctor, finding this magic cure, and there is no magic cure. This is lifestyle, this is work. Because it's taken some time to get here, we have to slowly undo all these changes. Evaluate the stress and determine the impact on the quality of life. Explain to the patient how stress and anxiety related. And I think we do this pretty well in integrative medicine, but just that connection for some patients, sometimes some of them have a eureka moment, and then they're better able to go back and see how stress is impacting and anxiety impacting on what their child is doing. Explain the importance of behavioral therapy and highlight that stress reduction is not the goal, rather it's coping, right? The stress is not going to go away, but how we cope and deal with it is important. Psychologist is critical, and do not limit to meds alone, but offer all brain-gut therapies or gut-brain therapies. And again, we're in the field of integrative medicine, we know what those are. The big thing is that the parent and caregiver need to be willing. We see kids where they're not willing, and as my mother used to say, it's kind of like taking an animal to the water and say, make it drink. It doesn't work. It just doesn't work. So they have to want to do it. We have to set realistic expectations, like your pain's not going to go away tomorrow. It's like we're going to work towards this goal. Share high quality resources, which we all have access to, but work as a team. So if you're a specialist or psychologist, you need to involve the pediatrician. If you're a pediatrician, communicate with the specialists that are being seen. So again, this group therapy, and I think the patients where this is most successful is where that group, that team spirit is incorporated. And then celebrate the small wins. Oh, you were able to try a new food, or you were able to look at food, you were able to smell this food in the house, and it didn't set you off. And that encourages ongoing participation. So this is another a nice cartoon of nutrition interventions for the disorders of brain gut. So what's in red is where there is evidence-based, and the green is where there's some information. So I said reflux is DGBI, right? And so elimination of cow's milk in the mother's diet for breastfeeding, and non-breastfed, then thickening could be used, and cow's milk elimination. So trying a formula that's not cow's milk based. For infant colic, again, if they're breastfeeding, elimination of the cow's milk in the mother's diet, and potentially other elimination diets, and non-breastfeeding using a formula that's not cow's milk based. For functional constipation, again, cow's milk elimination could be tried, and but normal fiber and fluid intake, some controversy about this, but in general, the evidence says fiber doesn't make a difference, and fluid doesn't make a difference. Sorry, normal fiber and fluid is okay. For predominant DGBI, mainly IBS, soluble fiber can work, and there's data in pediatrics about low FODMAP, single carbohydrate elimination like lactose, enzyme supplementation, plus minus on that, and other diets like gluten restriction. And this table actually goes through the data, etc., and the considerations. So again, a very nice paper by Narco in 2022. How about nutraceuticals? So really, there are these great papers with these infographics, which I thought was kind of cool. So for infantile colic, fennel and tea, fennel seed oil or tea, and then these herbs, a blend of these herbs. There is some evidence for this. Peppermint plus minus, but has been used. And then for breastfed infants, L-reuteri has been used as well. For functional abdominal pain, again, see how it creeps in. It should be abdominal pain, NOS, not otherwise specified. It's corn fiber cookies have been used, partial hydrolyzed guar gum, L-reuteri again, and then peppermint. Peppermint is really effective, I would say, and we'll go over the data. And for IBS, vitamin D, again, STW5, which is a blend of 5 herbs, peppermint, L-rhamnosus GG, and then psyllium and partially hydrolyzed guar gum. Now, this is a very brief mention of the interaction with the autonomic nervous system, especially looking at POTS or orthostatic intolerance. And there's this very nice connection between the gut, the brain, and the heart, right? And so when we see these patients, we really need to make sure, in addition to getting good GI symptom history, also symptoms of autonomic function, intolerance. We need to look at anxiety, depression, sleep, eating habits, physical activity, school function, attendance, peer relationships, and family functioning. As with Laura, you saw all these things were important. And then the interventions are really related to orthostasis, nutrition, exercise, physical activity, complementary innovative health interventions, psychological, and then pharmacological, in that order. So medications we do as last, but we try to implement all these first. And you know that you might need a team of people to help with these patients. We certainly have a team here, and even then we're not that successful. So a tough group. So coming back to our picture. So for irritable bowel syndrome, we talked about diet briefly, the herbal supplements, the other supplements like psyllium, probiotics, vitamin D. I didn't talk about SIBO therapy, but bacterial overgrowth is also happens. And herbal, there's only one paper on herbal therapy by Mullen in 2014, but showed that the herbs that he used were as effective as rifaximin, and then antibiotic therapy, which we all use. And healing systems, there are approaches in TCM, Ayurveda, and the new kid on the block is IB-Stim, which I feel has borrowed from acupuncture, auricular acupuncture, but it's on the market in some states, insurance covers it. And then the mind-body therapies like hypnotherapy, CBT, exposure, mindfulness, acupuncture, physical activity, and yoga. So I want to talk about this paper. This is from the Vliger group from Amsterdam. And this is long-term follow-up of individual therapies delivered and standardized, therapist delivered and standardized hypnotherapy recordings in IBS and abdominal pain. And really, if you look at the treatment successes, very nice treatment success with a long-term 6-year follow-up with positive results in more than 80%. Isn't that huge? Persistent improvements in these patients. For IBS and probiotics, everyone wants to use probiotics. This was meta-analysis. 3 had positive impact, 3 showed no difference, and 1 actually showed worsening of bloating. Peppermint oil works by smooth muscle relaxation, the calcium channel. It normalizes orocecal transit time. There's kappa opioid agonist activity, anti-inflammatory activities, 5-HT3 antagonism, relaxes the esophagus. That's why you don't want to use it in patients with reflux. And then in these 2 studies, reduction in pain, etc. This is a nice review for those of you who are interested in herbals, where Fifi et al. From 2018 reviewed all the papers on peppermint oil. There's 6 of them. And again, improvement in symptoms. Also looked at STW, again, improvement in symptoms. Looked at turmeric and curcumin for functional gastrointestinal disorders. This is not IBD, and did see some improvement in there. No differences here. And then aloe vera for functional GI disorders, not very good literature, 3 subjects, 3 papers rather. Now, how about myofascial release or massage? This is a study that we're doing right now at CHOP. This is our flyer, and we're still recruiting. So far, we have 14 subjects. You can see their ages and the different types of IBS they have based on the Room 4 criteria. And we have seen improvements in quality of life, whether it's a teen report or parent report, and then also with both IBS-associated symptoms as well as short-term quality of life improvement. But more to come on this. These are very preliminary results. And for those of you who don't know what myofascial release is, it's this very gentle release of the fascia, which is a form of massage, and you need special training in it. But I would say very powerful. And we teach the kids self-massage techniques to practice in between sessions. They're weekly sessions, once a week for 6 weeks. And we're also looking at the microbiome. I wanted to share this paper with you. on the exploring of the gut exercise link. And remember, I showed you our results where exercise or sports was one of the key, was a top resilience a tool that patients were using. So moderate intensity exercise is very beneficial, well tolerated, but high intensity requires monitoring. So this is important. So walking is a great thing, but if your patient is doing like high intensity soccer or but it's very stressful, etc., you need to really balance things out and see if they're getting worse with the activity. And then personalized strategies are very important, and then further research is important, but changes are happening in the gut microbiota with exercise. Now, this is a very nice summary, and if there's one thing you take from this paper for practicing pediatricians, I think this is a very nice paper on irritable bowel syndrome. These are guidelines from the Peds GI community in the US as well as Europe. And so green is high-grade evidence, dark green. This green is moderate, low is yellow, and then very low is red. And then best practice is white. So once you have a diagnosis, you explain the brain-gut connection, lifestyle education, how to identify symptom triggers, and explain the treatment approach. Remember that first slide about the psychological approach? You need to go over all that. Decide what they are, IBS-C, IBS-D. These are the medications used. But hypnotherapy, soluble dietary fiber, L-rhamnosus GG, CBT, low, but this, see how this is green, so moderate therapy. These are the antispasmodics, best practice. Auricular neurostim, this is the IB stim device I mentioned. Again, it's moderate inflammation. Amitriptyline, which is used a lot, low, and then refer to a multidisciplinary program. For abdominal pain, again, explain everything. Hypnotherapy, followed by CBT, peppermint capsules, cyproheptadine, low evidence, domperidone, which I don't think we have in the US, multi-strain, pro and symbiotics, hyoscyamine, auricular stim, amitriptyline, and then refer to a multi-D program. Okay, so very briefly, moving into functional dyspepsia, again, dietary approaches, so small frequent meals. These are the herbals that have been used. TCM, Ayurveda, IB stim have been shown to be, there's some evidence there. And then the mind-body therapies, acupuncture, hypnosis, tuina, we talked about that earlier. And then diaphragmatic breathing, again, we're vagal strengthening here. Acupressure points for nausea, everyone knows about P6, and in this picture is ST36, which is good for high school students. They can lean down and press this point in their knee, and no one is the wiser. Integrative approach to constipation, we have natural products. Fiber, I said there's no data in children, but people use this a lot. There are studies on this, pre and probiotics. Herbals have been used. This was a new thing where they compared this herb, I think it's a Persian herb, to polyethylene glycol with equivalent results. TCM, Ayurveda have things for this, and then all the mind-body therapies which can be used. Tuina, acupuncture, hypnosis, etc. Pelvic floor therapy, this is being used more and more. For colic, I threw this in, cow's milk elimination, the breastfeeding mother, and changing the cow's milk and formula to non-cow's milk for infants. L-reuteri, B-lactis, and fennel have been used. And then spinal manipulation, there is some data on this, acupuncture, and then massage. So coming back to Laura, where could integrative modalities be positioned? So she's poor sleep. She sleeps late, wakes up unrested because she has to go to school. She's not previously tried integrative health therapies, but she's interested. There are many stresses in school and her family, as we reviewed. She eats a lot of junk food and takeout, irregular schedule, eats late. She's a very sedentary lifestyle with minimal activity, and she likes to spend time with her boyfriend and her friends online. So what we did with her medications, we put her on cyproheptadine at night with a goal to decrease over time. We continued her omeprazole. We increased her vitamin D because her level was low to 2,000 units. We continued the ondansetron, use as needed. The erythromycin, because of the gastroparesis, we continued. We continued the polyethylene glycol packet and the multivitamin with minerals because her diet was not very good. And so our integrative plan for her was daily physical activity and nature therapy for at least 20 to 30 minutes a day. She lived with her grandparents in the suburbs, so it was easy for her to just spend half an hour or walk home from school in nature. We taught her breath work, the 4-7-8 breath, and we worked on sleep hygiene, which was something new for her. Then we talked about mindfulness, and we specifically taught her the 5-finger breath. We talked about apps. We taught her the acupressure points. She did not want acupuncture because she was needle phobic, but these points worked well for her. We did hypnosis. We recorded a session. We talked about diaphragmatic breathing, self-regulation. We gave her aromatherapy, and we also connected her with a psychologist. We shifted for nutrition. We shifted her time of eating. Remember, she was eating late, not having breakfast. We talked about ginger and chamomile tea, not peppermint tea because of a reflux. We talked about the gastroparesis diet, whole foods, vitamin D supplement, iron supplements because the iron stores were low, and this helped her sleep. We asked her to avoid ultra-processed food, artificial dyes, flavors, preservatives, emulsifiers as best she could. And we told her to go food shopping with the grandfather because in the house, the grandfather was making the food. And so we said, go with him. And he was making pasta sauce from scratch. So eat the food that he's making and go shopping with him and then cook with him. So Laura is using a variety of strategies to modulate nervous system activity and reduce symptoms. She's doing well. She still has nausea and abdominal pain in the morning. But she wakes up at 7. If she calms herself down, TikTok videos. She's now done school. Her nausea improves. I didn't approve the TikTok, but it worked. And then she says, I'm okay. So for her, that was her routine, right? She was able to eat a wide variety of foods, trying new foods and discovering she can tolerate them because she had all these reactions, which is why we saw her initially in our food reactions clinic. She's going to the gym every day with her boyfriend. She's going to the cola. It helps with nausea. Clinical hypnosis, she's practicing every day. Mandarin and lavender are helping her. The acupressure helped initially, but not using them anymore. And when she delays medicine, she feels worse, so she has to have a schedule. And she was doing well in school, now college, and wants to train in nursing. But what was most important, she wanted to get better. So very briefly, in the interest of time, I'll go through this quickly. So we started our program about 10 years ago, and we're now at 5 sites: our main hospital, our community hospital, our outpatient clinical practice here in the main hospital, at the Voorhees office, the King of Prussia satellite office, and then we have a new center for advanced behavioral health. We're there and at an inpatient facility. We aligned our strategic plan. We have a mission and a vision, and our strategic priorities align with the hospitals. Always important to do that. So we align around patient care, education, research, and so important in this day, financial optimization. We do not cover our costs, but we're striving to get there. This is a very busy slide, but it shows that we're active in the inpatient setting where we offer all these therapies. We have a TV channel where it's called the Relaxation Channel, where patients can tune in for offerings. We also have outpatient clinics, and soon to come is a yoga clinic. We have education for staff around breath. These are modules: breathwork, aromatherapy, Reiki, caring touch, which is massage. We have a symposium, we have a seminar, we have tailored classes and a variety of practices, and we also train our residents and other staff here. And for the community, we have family resources, group classes, especially massage, and we'll talk about these 2 programs. So we see more than 2,000 patients a year with about 8 staff, excluding myself, and I'm part-time. And then this quote is kind of typical of what we hear from our families. For yoga therapy, we started our program in 2017, pretty steady. The ups and downs have to do with replacing yoga therapists. This was hard because none of them had worked in a medical setting before, so we had to train them up, and anyone we bring on, we onboard them in the medical side of things, and then allow them to use their creativity. And we're going to start a clinic this fall. A massage, we started in 2018. The volume has increased dramatically. We have outpatient clinic. We work in the intensive rehab unit, and outpatient clinic for patients with CP. For acupuncture, we are in the ED based on how many acupuncturists we have, but we place seeds, bands as well as needles. We have, again, ups and downs based on staff availability. For aromatherapy, we have a nurse-initiated program that we started in 2018. So any patient 3 years and older can get this. We now have trained other people to provide it. We document in the nursing flow sheet. Of course, it's used more than it's documented. And these are the 3 essential oils we use, and the volume has really skyrocketed. We have an inpatient Reiki program. Nurses can request this. Again, encounters has increased. We have an online module as well, and we're training not just therapists, but and our staff, but nurses and even parents as well. We have a consult service that we started, I want to say in 22, and again, the volume has skyrocketed. We are able to add a nurse practitioner, and again, very, very positive results. We're really keen on empowering nurses. So we have modules for the nurses to use. Nurses can provide aromatherapy or a Reiki consult. And then we've trained 2 nurses to provide holistic care. And they act like a nurse practitioner, actually. They do consults with us, etc., provide training. At our King of Prussia Community Hospital, we don't have the full complement, but we have massage, yoga, Reiki, and holistic nursing. All the education is available there. Again, we are very creative with our holistic nurse. There's just not even maybe 1.5 FTE there if we combine everyone. We are embedded in our adolescent medicine eating disorders unit. We have nurse champions that get our therapies out in the unit. We have NICU massage classes. And again, very, very popular there. Patients, what they want is very positive response. Massage is the most popular, and stress and pain and well-being are the most common indications for referrals. Our education and training, we've trained residents, the University of Arizona program. We have our symposium. We've done 30 hours of culinary medicine, 20 hours of, this is just an FY24, and we have all these things available, including we're very excited about this, de-escalation of kids who get out of control in the hospital with integrative practices. Our research is in these areas. I've shared some of our research with you as pertinent to this topic. And then this is our wellness education in the community. We've trained more than 2,000, reached more than 2,000 people. Our first program was patients and their families. Second was school. Now we're in preschools. We're teaching preschool providers, again, with very positive results. Our culinary medicine program is robust. This is all the stuff that we've done. I'm not going to talk more about it, but just for you to know that we're going to be having a website where our recipes are all going to be virtual and accessible. So hopefully in the next few months, the website will be up and running. And this is our integrative health team. Not all are full-time. A lot of them are part-time. And I want to thank you for your attention and just draw your attention to our symposium that's coming. It's right in line with this topic, and would love for as many of you could attend if you can. It's virtual. So thank you.